Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population.
Every year, there are more than 13 million cases of acute kidney injury worldwide. Unfortunately, this disease burden is on the increase in emerging countries where the actual incidence is estimated to be 11.3 million. What is acute kidney injury, also known as AKI, and acute renal failure? And what are some of the causes and conditions that can lead to it?
Yeah, so happy to be here back with all you guys today. So in general, acute kidney injury, as you stated, formally referred to as acute renal failure. It's semantics, but it's now AKI. Acute kidney injury is, in its basis, a sudden drop in kidney function. Okay, just a decline in GFR or glomerular filtration rate, or other injury that affects the kidneys, usually reflected by an increase in creatinine, other metabolic markers such as BUN. And as far as, what can lead to acute kidney injury, the list is almost innumerable. It can be quite a lot. I mean, the most basics, just simple volume depletion, dehydration, a sudden drop in blood pressure, obviously hemorrhage. Anything that impairs blood flow to the kidneys will be reflected or usually will result in acute kidney injury, but it's a very, very long list that I'm sure we'll get into a number of more details as we get through this podcast today.
Acute kidney injury is common in patients who are in the hospital, in intensive care units, and especially in older adults. Why does AKI tend to occur in these patient populations? And as you're discussing that, maybe you can touch on some of the signs and symptoms that are tied to AKI where appropriate in these populations.
Yeah, it's a great question. And how I explain it to patients or patients' families is, the kidneys are often just a very good barometer of general illness. So a lot of things that put patients in the hospital for whatever reason will affect kidneys and kidney function, be it infection or pneumonia or in more severe cases, sepsis and the resulting drop in blood pressure. And again, just a lack of blood flow to the kidneys can cause them to kind of shut down and clamp down. Unfortunately, there's no tried and true symptoms of acute kidney injury, right? This is all based on blood work. And so it's with routine laboratory testing and measuring creatinine and also GFR and BUN and other things, it can be picked up on almost early on by just a drop in urine output, right? So sick patients that, have a catheter or we're monitoring output, very closely as usually is the case. Sometimes the call is, the labs don't look too different yet, but we're noticing that in the last 12 hours, their urine output's gone to near zero. So it's just the kidneys are unfortunately a downstream organ that we often see is influenced or takes hits or is negatively affected by just general illness, and especially severe illness for sure.
Dr. DiPette or Dr. Edwards, do either of you have a question before I ask another quick question?
Yeah. Could you talk a little bit about what the three different types of acute renal insufficiency or acute renal failure are?
I think what you're leaning towards is when we're talking about pre-renal, right, intrinsic renal, or post-renal. It's often, I remember in medical school and through residency that it's classified in that way. It is a good way to think about or at least try to troubleshoot what is causing the problem. So when we say pre-renal, we essentially mean the injury as a result of lack of blood flow to the kidneys. So whether, again, that's hypotension, whether that's hemorrhage and acute blood loss, I mean, even as far as clots and occlusion to the kidneys. So pre-renal essentially means something has caused a lack of blood flow to the kidneys, and as a result, they have shut down. Post-renal is very much what it sounds, and for first and foremost, that's usually obstruction. For our older gentleman population, you always have to think about prostate enlargement and lateral outlet obstruction as a result of that. You got to think about kidney stones, okay? And if you've got a kidney stone that is blocked ureter, that's obviously going to affect kidney function. And then when we're talking about intrinsic renal, I would probably say the least common of those three categories, but you always have to think about it. I mean, so is it something like an ankylosing, other autoimmune diseases? Is it AIN or acute interstitial nephritis? So essentially an allergic-like reaction that is developed in the kidneys, usually due to a drug of some sort. Thinking of those categories and therefore going through your list of what may be going on in your own mind, what I do on a daily basis, but what anyone should do to just kind of think, okay, what, something's changed. What's led to this change? What's happening?
Ben, I've often been told that acute tubular necrosis is a reasonably common renal form of AKI, but sometimes it's very difficult to understand. Thoughts on that?
Yeah, I mean, ATN or acute tubular necrosis is a very common cause of AKI. What can be difficult is that, especially in the hospital setting, we're not biopsying these patients the day we see them. You know what I mean? We're doing chart review and taking history and physical and sometimes we come up with our best guess as to what has led to an acute kidney injury. Sometimes ATN just seems to be a catch-all basket that it's got to be, and it's probably ATN from something, whether we know exactly what happened, when it happened, so be it. But ATN for sure is one of the most common resulting pathologies, no matter what set the injury off.
If AKI is suspected, are there certain tests to confirm the diagnosis and to point to a specific pathophysiologic process or disease?
Yeah, so AKI itself is a diagnosis based on lab work, right? So again, if we're speaking of hospitalized patients, especially sick ICU patients, and even if not, I mean, most patients are getting basic metabolic chemistries checked every day, other lab tests. And so it's identified as a rise in creatinine from one day to the next, or again, a decrease in GFR, which represents the same injury. I did have to go back and look actually before we just started this. I think depending on where you read, the textbook diagnosis is a rise of creatinine of, I think, 0.3 in 6 hours or more than 1.5, the baseline in 24 hours, something along those lines. But it's not subtle. It's a significant increase in creatinine from one day to the next, or a steady increase over the course of several days. Now, as far as are there certain labs to dictate or give indication of what caused the acute kidney injury? No, there's honestly, it's more subtle than that. You've got to, if I get called with an acute kidney injury consult in the hospital, the first thing I do is I pull up the chart and I see when the change in creatinine happened. And then I go back 24, 48, 72 hours in the chart and I look for when did the blood pressure drop? What medicines did they get? When did they get a contrasted CT scan? When did this happen? When did this, you got to put your investigator hat on a little bit and try to, as best you can, identify when the injury would have occurred, or to your best guess, what was the cause. And sometimes we don't know. I mean, sometimes we just, despite our best efforts, you can't really fully pinpoint what happened and when it happened.
Ben, is measuring the urinary electrolytes, like urinary sodium, is that helpful to distinguish? You mentioned the big three, components of AKI, but does that help, or are we beyond that?
I can only speak for myself. I never calculate a FENA. The residents always want to report to me what a FENA is, and that's a fractionary excretion of sodium. I guess for me, sometimes it may be able to lead you in one direction or not if you really just have no clue as to what happened, when it happened, what's going on. For me personally, I don't find much utility in it, because if it would suggest per mine was read, but that book that the residents carry around, if it suggests that it may be a post-renal injury, yes, that one right there, yes, that pocket notebook, that pocket medicine. If the FENA suggests that it may be a post-renal injury, but I have no evidence for that, and there's no history to support that, that doesn't mean that I don't think that it may be something else. So it may offer some benefit, but I guess in academics more useful than maybe in practice, in my opinion. Now,
I think that's
some of my partners may disagree. They may use that information a lot. I just personally don't.
But I think what you just said was very helpful to separate what we learn academically, and then how in the world are we practicing when we're in battle, in the hospital with these very acute patients.
It's probably a great exercise for the med students and training residents, and to really think about what's going on and what may have happened and where we're going. For me, it's not something that I need.
Before we jump into once a diagnosis is made and the next steps, we've touched on primarily kind of AKI in a hospital setting, but it can also occur in outpatient settings as well. Are there different causes of AKI diagnosed in the outpatient setting, especially if the patient doesn't need acute hospitalization?
I would say that there are yes and no. The same reasons that patients develop AKI in and out of the hospital are there. I mean, but we will see there are some reasons for AKI that are more common in the outpatient setting, okay, and not in a critical illness setting. I would say that very often I get outpatient referrals for acute kidney injury, and very often they, I would say that they're either true volume depletion or dehydration. Patient's been sick and had food poisoning and has nausea, vomiting, diarrhea, can't keep fluids down, truly dry as a chip, and someone checks blood in that time frame, and their creatinine is higher than what their previous baseline was. Again, in my older gentlemen, if I get referred from or get a referral with a pretty sudden or dramatic increase in creatinine from a baseline, I always have to think about bladder outlet obstruction, enlarged prostate issues, and so I will go down that route in that line of questioning. And then another big category that I see are heart failure patients, and that can be a very difficult population of patients to try to get a sense of what's going on. The definition in layman's term of heart failure is that your heart doesn't beat well enough to pump blood forward well enough to all your organs, and the kidneys are very sensitive to blood flow. So if these patients can have very wide ranging creatinines on any given day based on their volume status, and are they volume up and we need to be more aggressive with diuretics? Are they volume down and we've been too aggressive with diuretics, or everywhere in between? So that's a very common scenario that I get presented with on an outpatient setting. Now, on an inpatient setting, it's usually more critical illness, and it's usually hemodynamically driven for the most part. So again, I know I've said it, but low blood pressure, low heart rate, or the other way, AFib, aflutter, and tachycardia can interrupt blood flow to the kidneys just as much as a low heart rate. So you just gotta really, sift through the history and what's been going on, and try to get a best guess as you can as to what's causing your kidney dysfunction.
How likely is it of returning to normal kidney function after an episode of acute kidney injury? And sort of a second part of that question, what are some of the risk factors that we should be looking for that may make someone more or less likely to return to normal after an insult?
Yeah, no, great question. It depends on the cause of the injury. Let's take contrast nephropathy, just as an example. That's a common one we see. Kidney injury related to contrast dye, usually in the form of, in relation to a CT scan or some other thing, or left heart cath, but contrast nephropathy. The thing is, if that were to occur in a patient, when that hit happens, the injury is done, right? I mean, it's a one and done. You just have to kind of ride it out. When I am counseling patients or talking to them in this scenario, I go back and look and see what their baseline kidney function was. If a week ago they had normal kidney function and they had contrast exposure and they were unfortunate to have a contrast injury, I tell them, I fully expect this to recover. I fully expect it to recover back to your baseline. What I can't tell you or predict is how long that may take. Right? Some patients have a quick, rise in their creatinine, and then after 24, 48 hours, we're already on the mend and almost back to their normal. Some have a much more prolonged injury. So the best, I don't know if I can give you an answer as to what percentage of patients in any AKI scenario should recover, but for the most part, I expect recovery. Time is what I can't tell them how long it'll take. I think to answer your question, my best predictor of their recovery will be their baseline kidney function before the injury. If you have underlying chronic kidney disease and you have underlying loss of kidney function at your best, and you sustain an acute kidney injury, I am in no way nearly as optimistic that we're going to recover back to a good place. Yeah. I'm hopeful, but I definitely don't make those patients promises that things are going to get better.
Once an AKA diagnosis is made, what are some of the therapeutic next steps? And kind of another prong question for that is, if it is stabilized and we are looking to these next steps, are there long-term consequences of having had the AKI? And I know we've kind of touched on some of that, but if there are, how do you follow those and detect them as you look farther down the road with this patient, and not just the immediate care, but longer down the road?
The smoke and mirrors of my job to some degree is that, especially in the hospital, if I get called with an AKI, there's not much we're doing. We're following numbers, we're watching, we're hopefully following close enough to where if dialysis becomes an indication, we're there to offer that support. But, when I get called with an AKI, the damage has been done. So first and foremost, I want to, in my best way, try to at least explain or diagnose or pinpoint what exactly happened. And then, of course, make sure we're not doing things to perpetuate that injury. So if it's a medication-induced injury, I'm making sure that we're stopping those medications, that we are, avoiding other nephrotoxic agents as best as possible. If it's I think a pre-renal hypotension situation that has got us to where we are, then I'm making sure that everyone involved, the hospitalists, the nurses, the intensivists, whomever, know that we have a minimum blood pressure requirement that we're trying to keep, that if we need medicines to keep blood pressure up, that they're on those. If I think that it may be a post-renal injury, I'm making sure that there's a Foley in place, or that we are at least bladder scanning and make sure there's not an obstructive issue going on. I guess the best way I can answer that question is, for an acute kidney injury event, whatever happened, And my job then becomes, okay, let's keep as best we can other insults from occurring. And then support these patients and ride it out and have faith that the kidneys are pretty resilient organs and they can recover if we just, support patients and give them enough time.
We would be remiss if we didn't mention COVID-19 during this pandemic. Can COVID cause AKI? And if so, are there different approaches to care in this patient population?
COVID absolutely can cause an AKI. I am not going to be the expert on this particular subject. I think primarily because we don't know enough. It's too new. COVID, and especially in the bad cases, causes just massive critical illness and multi-organ system failure. And as I stated, the kidneys are sometimes just a barometer of illness. And so when a patient is sick and their lungs aren't working and their heart's not working, their kidneys are often the next organ system down. So we get called to see these crashing patients quite often. It's unfortunate that almost the mortality rate of a COVID positive patient who is in multi-organ system failure, and to the point where I'm being asked if they need dialysis, their mortality is almost 100%, at almost 100. And even the ones that we put on dialysis and they're on for weeks, they don't survive and they don't leave the hospital. It is a very, very bad prognostic factor if I get called because a patient is in multi-organ system failure from COVID-19 to the point where they need dialysis. It's bad. And I have to tell the families and the other practitioners that, listen, I'm not going to refuse to offer care, but you need to know that this is not going to end well. There seems to be what is being called COVAN, or COVID-associated nephropathy, that it seems to be developing. And it seems very similar to HIVAN, or HIV-associated nephropathy, which is a well-established and recognized medical condition. But there's something going on causing a glomerulitis or glomerulopathy from COVID specifically that's affecting kidneys. I can't tell you the incidence of that. I can't tell you how frequent it is. I'm not telling you, or how we would treat it differently than what we're already doing, offering supportive care. But I would imagine in the next few years, as we know more and learn more, and COVID, hopefully in our hindsight, that we will have more of an understanding of specifically what that pathophysiology is. But there is an association with COVID specifically outside of just sepsis and multi-organ system failure.
Dr. DiPette or Dr. Edwards, do you have any other questions?
I think Ben has done a wonderful job summarizing not only the inpatient aspects of AKI, but also we touched upon the outpatient aspects as well.
No, I appreciate it. This was really informative.
Are there any final thoughts or pearls that you would like to share with our listeners?
I would, actually. I've got an answer for this one. So when we're dealing with acute kidney injury, I would say there's always a reason. The kidneys just do not shut down for no reason, right? And more often than not, it's fairly common reasons. And so as a primary practitioner or an inpatient hospitalist or whomever, I'm not saying don't call me if you think that you need me, but go back in the chart, think where did the injury happen? I mean, the good news about kidney disease and acute kidney injury is you can usually pinpoint when the labs changed. And so you can go a little before that and go, okay, what happened that day? What were they doing? What new medicines did we start on? And there's always a reason. And part of, a lot of what I do, as I said, is a lot of investigation work and chart review and sleuthing to try to, as best I can, come up with the most reasonable explanation as to, where the kidney insult happened. And so, yeah, I guess I'm going to be my biggest pearl. There's always a reason.
Thank you. Once again, I appreciate everyone's time today. I think our listeners will have much information to take with them, and I appreciate your time. Thank you.
Thank you.
Welcome. Thank you.
Thank you, Ben.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcasts or subscribe to us on iTunes, Google, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org. And thank you for joining us.